It is an honor to be here with this elite panel of presenters, and I'm really thankful for the opportunity and for the sweet invitation. So I was asked by Professor Hesham to give a review over the ultrasound scans in infertility and how we could give some advice for the specialist while performing the infertility scans. So if we start with the initial and baseline evaluation of an infertile patient, we need to see the uterus and examine whatever pathology is present within the uterus. Then we move on into the adnexa, the ovaries and the tubes and whatever is beside the ovary. And then we should move on and not forget the utrovesical pouch and the Douglas pouch while evaluating. But I want to give an advice and a tip before starting all this. Start to activate your vaginal probe while performing a transvaginal scan at the vestibule of the vagina of the patient. And start to look at the different details that you can see while introducing your probe inside the vagina. And you could see that the anterior and posterior walls are opening. You could see the rectovaginal septum very nicely. You could see the rectum. You could see the bladder and the utrovesical pouch. And you should not miss a lesion that would be present in the vagina or in the cervix while performing such a scan, especially in prolapsed polyps or submucous myomas that has been prolapsed in the vagina. Of course, doing a speculum examination will give you an idea about what is the diagnosis, but not to miss them with an ultrasound scan is better by performing your scan just outside the vagina. And sometimes you could see like a cyst inside the vaginal wall, and this cyst could be either an embryological cyst, developmental cyst, or it could be a site of an endometriosis, and could be a site of dyspareunia for the patient. And as you can see here, this subtle lesion that is present and the external os, you would miss this if you just introduce the probe at the cervix and not looking at what is seen inside the vagina. And if you put a Doppler over this lesion, you could see that the pedicle is extending into the cervical canal, and you could see that it is actually arising from the lower part of the uterus, and it is a prolapsed endometrial polyp that you could see you could see it now very nicely and easily by doing the scan. So my advice, always activate your probe before introducing the vagina and start to look at the anatomy as much as possible. Moving on, you have to know what tools you have at the ultrasound. So you have 2D ultrasound scans, you have color Doppler, you can utilize the line infusion sonography to evaluate the uterus and the tubes. And of course, if you are fortunate enough and have a 3D modality in your scan or in your machine, of course, you use it and you have combination of these things together. So we have color 3D power Doppler, and you combine saline infusion sonography with 3D and you get these nice images of the cavity or pathologies inside. So we start with evaluating the uterus, and sometimes it is of course difficult to evaluate the uterus if the position of the uterus is not very nice. So in an anteverted retroflexed uterus that is pulled by adhesions, it's difficult to assess the endometrium sometimes. If the uterus is in erect position or high up in the pelvis, because it is pulled by adhesions, is sometimes difficult. Now, of course, if you have multiple lesions that are affecting the uterus, like multiple myomas over here, it becomes very difficult. So my tips, again, fill the bladder. Sometimes filling the bladder and evaluating the uterus through a transabdominal scan could be an option in difficult cases. And of course, using your bimanual examination. So with your other hand, you push over the pelvis and try to push the uterus as close as possible to the probe, and then you could see it more nicely. The uterus, what we need to evaluate the endometrium. We'll of course evaluate the myometrium and the lesions in the myometrium, and evaluating the cavity with 3D ultrasound or with 2D ultrasound is again one of the things that you have to see. While evaluating the endometrium, we start to look at the thickness of the endometrium, and we measure the thickness in the mid-sagittal plane, try to take a proper mid-sagittal plane, get an anteroposterior diameter or thickness of the endometrium, starting from the endometrium-myometrial junction to the other endometrium-myometrial junction. And if you have fluid, of course, You do not measure the fluid, you measure endometrium along the anterior and posterior walls. So we need, again, to correlate the thickness with the different parts of the menstrual cycle. So with immediately post-menstrual, of course, it's very thin, then it increases and increases and then increases during the luteal phase to have its homogeneous, usually echogenic appearance at the mid-luteal phase. And it is also important to correlate the thickness of the endometrium with what you see in the ovaries. So look at the ovaries, and usually during the follicular phase, when there's early development of the follicles, you see a very thin endometrium. And then later on in the mid-luteal phase, when you have a thick endometrium, you should see a corpus luteum in the ovary. But the problem happens if you are in a mid-luteal phase and you see a corpus luteum and the endometrium is very thin, or when you are immediately post-menstrual and you could see a thick endometrium that has not been properly shedded in the menses, and now this could indicate that there is something wrong with the endometrium and it's unhealthy for implantation. Endometrium morphology, we see the echogenicity of the endometrium, we see the midline interface, and we see the endometrium-myometrial junction. And usually we see a homogeneous endometrium, either isoechoic or hypo or hyperechoic. Sometimes you see heterogeneous endometrium with multiple echogenic areas within it, which indicates, again, a non-healthy endometrium for implantation sometimes. You could see a very thick cystic endometrium. You could see a cystic endometrium due to a cystic polyp inside the endometrium, or you could see multiple echogenic areas due to polyps within the endometrium. And my advice with these endometriums is always look at them post-menstrual before ordering any intervention. Sometimes you find all these things shedded and you find a normal endometrial interface, and sometimes you would need to do either a biopsy or to give medical treatment in order to treat cases like endometrial hyperplasia and so on and so forth. Moving on with the endometrial interface and the endometrium-myometrial junction. So with the interface, you should see it regularly, but if you see an interruption in the endometrial interface, could be caused by a polyp, as you can see here, or an abnormality in the endometrium-myometrial junction that is caused by something that is pushing from outside, like this submucous myomas. With color Doppler, it is important to evaluate the endometrium as well. You have to lower your PRF as much as possible to 0.3 to 0.6 kilohertz, and this could give you an idea about the extent of vascularity of the endometrium. There has been studies about subendometrial blood flow patterns, and it's not very well evidenced as a method to tell you what is the endometrial receptivity is. Because there has been this concept of endometrial receptivity. For a proper implantation or favorable implantation, you need a minimum thickness of 7 to 14 millimeter endometrium in the mid-luteal phase, a triple appearance. You would examine the uterine artery and you see pulsability index of less than 3, or a resistive index of less than 0.7, or you could see nice subendometrial blood flow extending into the endometrium. But all this is not very much evidence-based. The new evidence does not suggest that you have to take all these cutoffs, but the extremes of findings are important. So if you see a very thin endometrium in the mid-luteal phase, this is unfavorable. If you don't see any blood flow in the endometrium, again, with lowering the PRF, this is again abnormal. Or if you see an absent end diastolic flow in the uterine artery, this could be significant with decreased implantation. But again, this is not very well evidenced with the latest studies. With intra-cavitary lesions, you could see endometrial polyps, as you can see it here, with different sizes and different echogenicities. Sometimes it is hyperechoic, sometimes it is isoechoic as the endometrium. Sometimes it is difficult to be seen because you are seeing it in the mid-luteal phase sometimes, and it is covered by the surrounding endometrium. And my tips for polyps: use Doppler. It can give you an idea about the feeding vessel and the pedicle of the Doppler of the polyp. Always examine your polyps in a post-menstrual phase, because some of these polyps will detach, or it could be only an echogenic area in the endometrium and you will not see it in the post-menstrual area. And if you are suspicious, always use saline infusion sonography. Gives you a very nice idea about the shape of the cavity and whatever lesion that is present inside. So these are the 3 things that would help you to properly diagnose endometrial polyps. This was a very nice, interesting case. Was a post-menstrual small polyp. And as you can see, the polyp is moving with the uterine contraction down, and you could see the pedicle feeding vessel as it is feeding the polyp. And you can see that the pedicle actually is going up with the polyp and going down with the polyp. And this gives you a very good idea about where the pedicle is. If you're going in with hysteroscopy, it just it confirms the diagnosis. So intra-cavitary lesions as well as intrauterine adhesions, and you could see interrupted endometrial interfaces and with histories of DNCs or cesarean sections that has been complicated with postpartum hemorrhage or some cesarean sections that are not well done. You could see these lesions, and my tips again for intrauterine adhesions is you have to evaluate them in the mid-luteal phase when you have a thick, nice, thick endometrium to get an idea where the interruption is. And again, if you don't see them properly, use saline infusion sonography, and now you could see the adhesions very nicely with the interrupted endometrial interface. Intracavitary and extracavitary lesions include the fibroids, of course, that extends into the submucous area. So submucous fibroids, and we all know the different classification of different types of fibroids according to the FIGO in 2011, 2012, starting from 0 up to 7. And then we have the hybrid form, which is the 2 to 5 that extends along the endometrium, touching the endometrium and touching the serosal layer. So for example, this lesion, we could say that this is a 2-5 lesion in which it touches over here the endometrial interface and it extends into the serosa as well. And over here we have a type 4 that are completely interstitial, and again a type, you could say about it, it's a type 3, or you could see it's a type 2 to 5 again because it touches the endometrium, causing slight obliteration of the upper part of the cavity, and again it touches the serosa. And the impact of the different types of fibroids with infertility you all know about, and it is a big debate: should we remove or should we not remove? And of course, intracavitary lesions should be removed. Sometimes it's very difficult, again, to assess the cavity when there is multiple fibroids. And my advice for these cases should always see them in the mid-luteal phase when you have a proper endometrium and you could see where the myomas are. With the tips with the fibroids, you could see blood vessels, and over here the vascularity is peripherally along the myoma, not a feeding vessel like that of a polyp. Always evaluate the submucous myomas in a mid-luteal phase where you have a proper contrast from the endometrium. And again, saline infusion sonography could solve the problem where you push some fluid and you could see the origin of the myoma, and the type of the myoma can be very clearly seen. With subserous myomas that are extending into the adnexa, sometimes it's confused with a solid adnexal mass. And in order to confirm that it is a submucous myoma, the tip is you have to find a connecting vessel with the uterus. So the pedicle, you could see the pedicle and you could see the feeding vessel, and you could again see an ipsilateral normal ovary with these lesions. Moving on with adenomyosis that affects the uterus. We all know how the adenomyosis looks like now. There has been a lot of studies explaining the different signs and the power of each sign in order to diagnose, and asymmetrical enlargement with heterogeneous myometrium, subendometrial, and non-vascular cysts, sun-ray appearance. All this indicates that what you are seeing is an adenomyosis. And I need you to take care if you see what looks like fibroid, but you cannot measure this fibroid because you are unable to detect where it starts and where it ends. You're actually looking at probably an adenomyosis rather than a fibroid. And I, again, want to emphasize that the uterus is a dynamic organ. It undergoes contraction. So with this uterus, you could see that the posterior wall, the anterior wall, actually, this is an RVF uterus, is thicker than the anterior wall. And you could think that there is something wrong with the posterior wall, maybe an adenomyosis, but actually this is a uterine contraction. And if you waited for half an hour, you would see that the uterus returns back to its normal appearance, and you will not suspect that this is an adenomyosis. So again, if you have asymmetrical enlargement, wait for uterine relaxation. It could be a uterine relaxation. And with the fibroids, if you cannot measure them, it's probably an adenomyosis. Moving on into the shape of the cavity, you could imagine the shape of the cavity by moving from one side to the other. through a sagittal plane or from moving from below to up in a transverse plane, and you put all these images in your mind, and you could say that this is a normally appearing uterine cavity. Or if you see an interrupted endometrial interface, or you see two horns like these two horns over here, you would say in your mind again that this is probably something wrong with the cavity, maybe a bicornate uterus or maybe a septate uterus. And if you go up from the cervix to the corneal end and you see that it tapers into one corneal end rather than into both corneal ends, and it's not getting wider up, then you would say that this is probably a unicornate uterus. And of course, if you have a 3D machine with softwares and nice images, you could get these very nice images about the shape of the cavity, whether it is a septate uterus or bicornate uterus or unicornate uterus, unicornate with a rudimentary horn or a T-shaped cavity. And of course, with the 3D, you could again evaluate polyps, appearance, you could evaluate the uterine invasion of submucous myomas and the degree of invasion of the submucous myomas. And adhesions, again, could be easily seen as filling defects within the endometrium. Moving on into the adnexa, and we examine the ovaries. Of course, the intrafollicular count, you're all much better than me in evaluating the number of follicles and functioning follicles. And when you go on with the menstrual cycle, you could see that a developing follicle and a mature follicle or a dominant follicle takes the upper hand and becomes its maximum size when again it ruptures and then gives us the corpus luteum in the mid-luteal phase. And you would see this appearance. A lot of debate is there on about the number of follicles that you should count to say that this is a polycystic ovary. Should you call it a polycystic? Because patients starts to say, oh, we have cysts, I have cysts, I have to get rid of my cysts. It's better to call it a multifollicular ovary with a high risk of hyperandrogenism. And the criteria was that if you see more than 10 of these follicles, then there is a problem. Now, of course, it has increased up to 20 to 25 follicles. After that, you would say that this is a polycystic ovary having a high risk of development of hyperandrogenism and a high risk of development of ovarian hyperstimulation syndrome with induction of ovulation and a very thick stroma. With endometriomas, when you see them in the ovary, you see typical appearance of an endometrioma, and this is seen in about 51% of cases. But sometimes you see atypical appearance, and this is about 49%. So about 50% of the cases would be an atypical appearance. And the typical appearance, we all know about it: low-level ground glass appearance, low-level homogenic content, which is homogeneous. Unilocular could be multilocular up to 4 loculi, and you do not see any Doppler signal within the cyst, and very limited Doppler signal in the periphery or in the walls. But the atypical appearance could be echogenic, more echogenic content inside the cyst, and this could get a differential diagnosis with dermoids sometimes, and you could sometimes be confused. You could see a fluid level with the different densities of tissues that is or content that is present inside an endometrioma, or sometimes very rarely you could see it a hypoechoic cyst similar to a functional cyst or a simple cyst. And my advice with these atypical endometriomas is that you have to relate them to the symptomatology of the patient in order to reach diagnosis. So when you have an atypical appearance of an endometrioma, if the patient has the typical symptoms of endometriosis, you're probably looking at an atypical endometrioma. And appreciating that there are atypical forms helps you with the diagnosis. Again, if you see extensive adhesions inside the pelvis, kissing ovaries, or extensive inclusion cysts, then you would say that probably what you're looking at is an endometrioma rather than a hemorrhagic cyst or something else. Moving on into lesions in the ovary, so dermoid cysts, the tips in the dermoid cyst is extensive heterogeneity in the content within the cyst. Acoustic shadowing is very, very important, and dots and, as you can see over here, dots and lines that indicates hair inside, acoustic shadowing over here, and extensive heterogeneity in its content usually gives you an idea. If you put Doppler, you will not find usually any Doppler signal or very limited Doppler signal at the periphery. Moving on into things that are beside the tube, beside the ovary, sorry. So the tubes, you actually could see them if you have some fluid inside the uterine cavity, inside the pelvis, and if you have a very nice machine. So as you can see over here, you could see the fimbrial end, and you could see the tube surrounding the ovary when you have some fluid. But sometimes, of course, you could see pathologies inside the ovary. For example, the snake-like appearance of hydrosalpinx caused by PID, and you could see cogwheel appearance over here with the small mucosal folds that are present within the wall of the tubes. Or you could see this nice appearing cysts that open into each other. And this is a very important tip with hydrosalpinx. When you see them opening, you see like cysts, and then when you move with the cyst, it opens and it unfolds into each other, indicating that this is actually a tube rather than a cyst. And my tips again for a hydrosalpinx or a tubal lesion is you have to start from the corneal end of the uterus. So you take a transverse section of the uterus up to the fundus, and then you start from the corneal end and you move to the ovary. And probably if there is something wrong, you would see it in this area between the uterus and the ovary over here. So as you can see over here, the lesion will come, yes. And here, this is the lesion, and this is another small lesion, and it opens all together into what is the hydrosalpinx. Again, once you see something cystic around the ovary, always put Doppler, because sometimes it is only pelvic congestion and there is no hydrosalpinx there, and you could go into an operation occluding the tubes based on these cysts, but then they are only pelvic adhesions. Again, with the tube, if you want to test tubal patency, you push some fluid inside the uterine cavity, and you see the Douglas pouch. If there is some fluid in the Douglas pouch, most probably one of the tubes, at least one of the tubes, is patent. Of course, you should see that there's nothing in the Douglas pouch before starting the SIS. Again, there has been a lot of talk about tubal patency with hycosi, and there has been a proposal since 2016 using like homemade foam, actually clinic-made foam. So you put 3 milliliters of sterile gel with 7 milliliters of purified water and saline, and then you mix them together, you get this foam, and then you start to inject. And while injecting, you go into the corneal ends and you start to see if the echogenic contrast media, which is the foam now, is moving into the tubes and coming out of the tube into around the ovary. That indicates patency. It's not that easy, and you could miss the tubes. And there has been a talk about, or there has been studies about 3D, utilizing 3D with hycosi and 3D with hyphosi, which is the foam. And again, the results are very promising, and people who have very good technique doing it could have very high sensitivity and specificity as regards tubal patency. Things beside the tube, you could see a paraovarian cyst, and the tip with the paraovarian cyst is you have to push between the cyst and the ovary, and if they are separate from each other, then this is a unilocular, simple paraovarian cyst. You usually see it with a thin wall, no Doppler flow, and there is no solid content, or sometimes there is a very small solid content inside that is not vascular. Again, things beside the ovary, you could see a solid mass beside the ovary, and it could be, as we said, a subserous fibroid, and you should see the connection with the uterus through the vascular content. And if you see a normal ipsilateral ovary at the side, then you are sure about the diagnosis. If you do not see the connection and you do not see an ipsilateral ovary, it could be a fibroma, and they give the same appearance as a subserous fibroid. Last but not least is peritoneal inclusion cyst that could be surrounding the nexa and surrounding the ovary. And when you push over the ovary, you could see that the ovary is not moving properly, is limited mobility, and there is a lot of adhesions around. And when you push with your other hand, as you can see over here, that the intestine actually moves, and doesn't move. So this indicates that this is actually fluid, and it is within adhesions inside the ovary. And if you see these adhesions go into the Douglas pouch and do the sliding test, when you push over the uterus at the lower part of the Douglas pouch, you see things sliding over the uterus. And when you go in the upper part of the uterus and you push over the fundus, you see things again sliding over the uterus, which indicates that there is no adhesions. And this relieves you if it is a cause of infertility, or if you're going to surgery, you are not that worried. And in an RVF uterus, again, you can push against the fundus, and you can see that the fundus is moving over here against the rectum. And you can push again with your hand, and you could see that intestine is not attached to the anterior abdominal wall. And sometimes, and again, the anterior compartment is very important. You go into the uterovesical pouch and you push, and you could see that the bladder is sliding very nicely over the uterus, and there is no obliteration of the anterior compartment or the uterovesical pouch. But sometimes, of course, you would see these adhesions, extensive obliteration of the Douglas pouch and anteverted retroflexed uterus, and you know that it is either an indication of deep infiltrating endometriosis, and the surgery will be very difficult. Of course, Dr. Mohammed Mabrouk will talk about all this, and you could say that the adhesions could be a cause of infertility in these cases. So to conclude, always know your tools that you use and how to use the different tools in evaluating the pelvis. Check the vagina and the cervix, as we said, by activating your probe at the vaginal vestibule. Use saline infusion sonography and timed scan, either post-menstrual or mid-luteal, in order to detect different pathologies. Appreciate atypical endometriosis because they constitute about 50% of the cases, and check beside the ovaries, starting from the corneal end of the uterus, so that you will not miss an adnexal lesion. And thank you very much.
Thank you very much, dear Hesham, for an excellent presentation and a wealth of ultrasound photos. Actually, you have a very good collection of ultrasound photos. Thank you very much. Can we put the vote? And while they are voting, I will ask Hesham some questions.
Yes, sure.
So we have a question here from the attendees. What about the occasional appearance of intrauterine fluid?
Yes. So
how often do you see this, and what is the prognosis?
Okay, so intrauterine fluid, you could see them either immediately post-menstrual in the cases that has some residual blood inside the endometrium. Sometimes you see them in the mid-luteal phase when there's excessive endometrial secretions. Sometimes you see them in a post-menopausal patient when you have atrophic endometritis. So it's different according to what you are seeing them, where you are seeing them, and when you are seeing them. Usually, if you're talking about prognosis as regards fertility, if it is a non-consistent condition, usually it is not a problem. So probably you will wait for the next menstrual cycle, and most probably you'll not see them. And of course, if there is a lesion, so for example, if you see a post-menopausal patient with fluid inside the cavity and you see like a polyp or a lesion inside, then you're worried that this could be blood and there is a cervical stenosis, and this is actually hematometria, not clear fluid. And now you have to diagnose with a biopsy or see what is happening.
Professor Kasper, if you see fluid during IVF, just before pickup or after pickup, does it change anything in your management?
No, I think that's pretty common. I think there's physiologic fluid that develops as the follicles grow. So I don't think that's the problem.
Okay. Dr. Mackins?
As long as the follicles are still there.
Okay. Yes. Look.
Yes, in practice, we have we often check the endometrium again at the luteal phase. And what you often see is that fluid that was there in the follicular phase indeed disappears. So it's always important to check. But if the fluid remains, then we often cancel the transfer. And then we try for another cycle. But indeed, some patients, they consistently have this problem in multiple cycles. Sometimes unexplained.
Hesham, what are the normal dimensions of the uterus? The normal uterus, anteroposterior.
And if you're talking about a patient that has delivered a couple of times, or a patient that nullipara, we usually go for the 2, 3, and 5 inches. So we have the thickness of 2, the length, the width of 3, and the length of 7, 7.5 centimeters, and 5 and 2.5.
sometimes measurement of the endometrium is very difficult.
Yes.
Because of the angulation of the uterus or whatever. What do you do when this happens?
Well, sometimes if you can get a very nice proper angulation of your probe, that would be nice. If you push by manually, you can correct sometimes the uterus. Sometimes you fill the bladder and then see the uterus correcting its position. Sometimes you fill the bladder and then empty the bladder, and the correction is improved. Sometimes you do a 3D and then get a nice mid-sagittal plane where you can measure it. So you can use some tricks with difficult endometrium, and yeah, but sometimes it's very challenging.
Yeah, Professor Kasper, how often you cannot measure the endometrial thickness?
Not too often. I think with the vaginal probe, you can usually, especially as Hesham mentioned, you can move the uterus with your abdominal hand too, so you can see it better. So I think most of the time you can see the endometrial lining. I think if you can't see it, it means there's probably some major abnormality, either anatomical or otherwise.
Dr. Mackens?
Yes, I agree. We also don't encounter it that often that we cannot nicely measure. Only, for example, for uteruses with a lot of fibroids, then it might be difficult. But if there is no other pathology, often you can see the endometrium quite nicely.
What is the rate of variation between an observer and another in measuring endometrial thickness, and between the same observer? And we'll start on the reverse order, Professor Kasper first, then Professor Mackens, then Hesham. How much do I differ with myself and with you, sir?
I don't know. I think if you've got a high quality machine and you magnify the image, it's probably fairly small variability, but I think Hisham's the expert. I'd like to hear what he has to say.
Dr. Mackens?
Well, we see in our clinic that there is quite some difference, but as Professor Kasper explains, when you really magnify the image, probably we can decrease this inter-observer variety. However, in clinical practice, I think there is quite some difference in between measurements. Also for myself, yeah, within the same patients on the same day, probably.
Yes, yes.
Any tips, Hesham?
No, it's the same thing, and I think it all depends upon the machine, the settings that you are doing with the machine. If you changed actually the setting in the machine, so you're doing a gynecology setting, then you change into an obstetric setting, and then go into first trimester setting, you can see differences in the echoes and the contrast and where you should put the cursor. But I think the differences are not that great. So I don't think it will be, again, important as regards these very small millimeters, maybe a fraction of a millimeter in the difference. It's not that much of, as long as you know your anatomy, you are measuring actually an anteroposterior rather than a uterus that is anteverted retroflex, and you're measuring and it's axially rotated, so you're measuring actually an oblique view rather than a proper anteroposterior view. So if you are proper in your anatomy, I think the differences will not be that significant. But I don't know about the studies, I'm sorry.
Thank you very much. Can you see the poll now, Hesham? The results of the poll are there. Can we stop, Akram? And please read the questions, Hesham, and comment on the answer. You know the right answer.
Yes, yes, sure. So the questions were simple, and I think most of them will have answered it properly. So when starting your transvaginal scan, it is important to activate the propoid still in the vaginal vestibule, and about 80% of the attendees actually got it right. And I need to emphasize that you will see, if you will not see these lesions, and you will see these lesions when you activate your probe, especially cervical. The cervix is usually missed as an organ to be diagnosed. The tools used in scanning an infertile patient, about 100% of all the attendees got it right. You could use all the modalities that are available in your machine, 2D, the Doppler, the 3D, the sonohystrography, in order to evaluate your infertile patient. Uterine RT Doppler PI is the best predictor of endometrial receptivity. This has been debunked. It was for a while proper cutoffs, and it was said that when you measure the PI in the mid-luteal phase, a PI of less than an RI of less than 0.7, a PI of less than 3 would indicate that there is proper vascularity going to the endometrium, and this gives an idea that endometrial receptivity is good and implantation rate will increase, but this is not true anymore. Atypical appearance of endometriomas are very rare. I've emphasized this a couple of times, but still 50% got it wrong. It is about 50%, 49% of cases of endometriomas are all atypical. So knowing the atypical appearance is very important to appreciate the diagnosis and get a proper diagnosis. And visualizing fluid in the Douglas pouch after performing sonohystrography indicates that at least one fallopian tube is patent. Both fallopian tubes are normal and patent. No hydrosalpinx is present, and none of the above. 85% got it right. Yes, at least one tube is patent. You are unable, if you only see Douglas pouch fluid, you are unable to say that both the tubes are patent, and you cannot exclude hydrosalpinx as well. So I think most of the attendees got it right. Yes.
Thank you very much, my dear friend. Excellent presentation.
Thank you for the opportunity.
Enjoyed your presentation and your discussion. Thank you very much. And
thank you for the opportunity. Thank you.